Alright, this is cardiopulmonary lecture number 5. We're starting with spirometry this time. Most of you are familiar with spirometry. This is that pulmonary function test that most asthmatics have to do on a regular basis. Then there are some patients that need to do spirometry for different reasons, such as fit testing for respirators. Some patients may have to do these because of cardiac problems. So let's look at what is spirometry, what are we looking at, and how to interpret some of these readings. So spirometry, thank goodness, is a non-invasive screening test that we can do there in the office. I've even done these out on a portable machine out in the field. So if we've gone and done maybe some health fairs or some screenings at the job site, that's something that's easily done. So what the spirometer does is it is a computerized electronic instrument that measures the amount of the air that is expelled from the lungs and the rate at which the air is expelled. So those are the two important things I want you to remember about what is a spirometer. And what happens is it gives us a printout at the end of the test to tell us a little bit about what the machine actually saw from the inside. So how does it work? We can use this for screening devices. We can also use the results to see if we need to change medications for a patient, or even send a patient for further testing. Here are some of the indications for spirometry testing. Patients that have lung dysfunctions, such as dyspnea, which is of course the shortness of breath. Patients that are at a high risk for lung diseases, such as your smokers, and the patients that are constantly exposed to environmental pollutants. So even your farmers and your folks that are around a lot of chemicals. Asbestos is another one of those. So you've got people that are construction workers that are exposed to a lot of chemicals on a regular basis. Alright, some of those lung disease problems could be asthma, chronic bronchitis, and emphysema. Sometimes those patients end up needing to go and have surgery, so after they recover from surgery we need to do another spirometry test, and they really don't like us for that point, having to do it at that time, because they're typically very, very sore, and the spirometry is not a very fun test, especially when you're sick. So there's one thing that we test with spirometry. It's called the forced vital capacity, FVC. So basically what we're doing is we are actually testing to see how fast that patient can blow out their first breath of oxygen. So they take in the biggest, deepest breath that they can, put the instrument in their mouth, and then they blow as hard as they can for that first second, and then they keep blowing, keep blowing, keep blowing, keep blowing. So it's telling us the big thing for the forced vital capacity. This is the maximum volume of the air that can be expired, meaning blowing out, when the patient exhales as forcefully and as rapidly as possible for as long as possible. So that's the book terms for exactly what I just said. Alright, then we actually get to see this in FEV1 after that first second. So it breaks it down even further when we're looking at those results. Then you have the FEV1 and FVC ratio. This is going to tell us where our patients are at within that first second, and then the forced vital capacity, as hard as they're breathing. And their patients with healthy lungs have about 70 to 75% of air with that forced vital capacity is expelled. So what you're going to see, and what will be a little bit alarming to you, is when those patients that have chronic respiratory illnesses that have things like COPD, emphysema, their ratio is actually going to be less than 70 to 75%. So got to be careful, because we don't want them to exert themselves so hard that they pass out completely, but I have had several to actually pass out. That means they're actually doing their best effort. Okay, so some of the information that's important while we're doing the spirometry that we have to put into the computer so it can give us a range is the patient's age, sex, weight, and height. So that is going to be some very easy information that we can gather from the record, and then we also can verify that as we're entering it into the computer. So we have to do those little bits of information about the patient so it will have something to compare to. Now, some of the patient preparation that we should tell our patients before doing spirometry. So if it's a planned spirometry, we want to tell them not to eat a heavy meal 8 hours before coming to do the test, because unfortunately when the stomach is full it doesn't allow the lungs to expand fully. We want them to stop smoking at least 8 hours before the test if they're a smoker. And that's a hard thing, very, very hard thing. And then, of course, don't take the bronchodilators 4 hours before the test. And they're not using those inhalers, so that might be difficult for your asthmatics and your COPD patients that have to use those inhalers on a regular basis. We want them to come in and not to have been engaging in strenuous activity for 4 hours before the test. And then, excuse me, we would like for them to wear some loose, non-restrictive clothing so that their chest can be expanding easily, but they also feel comfortable when they're doing their deep breathing. Okay, so just like with every other instrument, we have to do calibration in order to assure that that instrument is running properly. So this is no different with a spirometer. So every day that we're going to use our spirometer, you must calibrate it. And it's really cool. You have this huge syringe that you hook your spirometer to, and you inject 3 liters of air into the machine. And what we do is we should get this really good reading from the instrument saying that it's within calibration. So you have to do that particular procedure every day. It's a good idea to do it every day, even if you don't have anyone planned coming in to do your spirometry. That way, if they come in and your doctor's like, okay, do a spirometry test, you're not holding them up. You can just go ahead and go in and do your spirometry testing. All right, sometimes your physician will say, you know, I want them to use this bronchodilator, and then I want you to do a spirometry test after that. Well, it's very important that we wait about 10 to 15 minutes until after they've used that bronchodilator to do the spirometry, and that way we can get a true reading as to if that bronchodilator is going to be working right for them. All right, so we want to make sure that they are not being obstructed while they're doing their spirometry testing. So what is asthma? Of course, asthma is that chronic lung disease that we commonly call reactive airway disease. And what happens is it affects those smaller bronchioles in the very bottom of the lungs, and it constricts them, so it makes it difficult for that patient to breathe. So what brings on those asthma attacks? Coughing, chest tightness, shortness of breath. You will see that they start having this audible noise called wheezing that we can tell that they're having that asthmatic attack. And you know, a lot of times those patients can be triggered by environmental things such as chemicals, perfumes, smoke, even outside around different types of plants that are blooming, dust, pollen. So anything and everything can exactly cause that patient to have an asthma attack. We just have to narrow it down and try to say, hey, let's try to avoid exposure to these things. And if you do have an exposure, be prepared to use your bronchodilator. So with asthmatic attacks, they do tend to vary in significance. Some of them are very minor, and some of them are very, very severe. And it's extremely scary for a patient. If you can imagine, normally we breathe very freely and we don't have any obstructions. So it's kind of like we're breathing through a toilet paper or a paper towel the paper part on the bottom that the actual paper is attached to. So we're able to breathe very comfortably without any restrictions. Well, when a patient that has asthma starts having an asthmatic attack, their bronchioles and alveoli, they start constricting, so they feel like they're breathing out of a straw, or maybe even smaller, out of a coffee stirrer straw. So it's not only very scary, but it's very uncomfortable. And this can happen, and it can last for about 10 to 15 minutes. So a lot of times we're really having to try to focus on the mental status of our patient, to try to get them to focus on your voice, focus on their breathing, to try to get it back to a normal state after we've given them those asthmatic bronchodilators. Okay, so we've just talked about all of this stuff. I'm not going to have you have to keep reading all this as we've talked about it. Diagnosis and treatment. Of course, we have to use spirometry in helping us with diagnosing those asthmatic patients, and the physician gets to use that concrete evidence from that PFT that they definitely have had some tightness of the bronchioles and the bronchi, and that they've had a good reaction to the bronchodilator, so it's actually relaxed all that constriction, that vasoconstriction that's going on. We also can do allergy testing, arterial blood gas studies, which I don't want to have done, but you know, hey, if we have to do it, we have to do it. All right, so long-term medications to control that asthma. Patients typically get put on a bronchodilator plus oral meds, and then of course we have to take that every day. Those quick relief medications, we call that rescue medicines. Those are like your albuterol treatments. Also, patients might be given a prescription for a nebulizer. So this is one of those home breathing machines that patients can do as needed, and sometimes on a routine basis, to help keep those those bronchioles and the bronchi good and relaxed rather than constricted. Okay, so this is all very familiar. There is a peak flow meter that your physician might have available in the office that they might want you to use, and that's something that you have a video to watch, but this just gives us a little bit more information as to how that patient is breathing with something very non-invasive. Okay, all right, so home oxygen therapy. This is another thing that you might be responsible for prescribing. This is definitely something that is a prescription. It is a medication. You cannot tell a patient to start using oxygen, to how many liters to take. That is definitely a prescription. It is a drug, so the physician has to order that. But oxygen, yes, it is a colorless, odorless, and tasteless gas. It is vital to our body. Absolutely, we have to have that so we can oxygenate all of our blood, keep all of our organs alive. So a lot of times our patients will come in and they're having oxygen that is at a low rate. So we see that their oxygen saturations are below the 100 rate, which we always want to score towards 100, but we start getting a little bit worried once they get into the lower 90s and below. So we see hypoxemia or hypoxia, and we don't want that to happen, so your physician typically will start prescribing that they have oxygen at home, and they use that at any time. So there's different ways to deliver that oxygen. So there's different masks, there's different prescriptions. I'm trying to get to the slide with all the masks. Okay, here we go. The face mask is one that is just plastic, and it fits over the nose and the mouth. It has some elastic that goes around the head, and that connects to some tubing from the mask that goes to the tank. There is another type of mask that has a It has a bag at the bottom, and that ensures that the patient is receiving 100% oxygen. There's also a nasal cannula that just goes into the nose and is more comfortable for most of your patients to wear, and this delivers oxygen straight into the nares. And some of the things you have to remember with your patients who are on oxygen therapy is the safety measures. We want them to store their oxygen in a clean, dry, well-ventilated room. We want them to stay away from heat sources, so do not smoke around that oxygen. It is combustible and flammable. I mean, it's just kind of a given. But a lot of patients you will see, they will be sitting around, and they'll be smoking their cigarettes with their oxygen on and their nasal cannula. I promise you that is not safe. Please advise your patients to keep any heat away from that oxygen. They do need to buy a fire extinguisher and have it available just in case they have an explosion or have some type of flame to come back. And then also they need to have smoke detectors. Alright, so this is the end of this lecture.